Yes, sir, we can start.
Thank you. Okay. Hello, hi everyone, and welcome to another session of the Thorax. I'm Dr. Ankit, your faculty of anatomy in our Oracle platform, and today we are going to discuss on an important topic of thorax, that is about the thoracic wall. Okay, just give me a second. Okay. Right. So today the topic that we are going to discuss is about the thoracic wall proper and thoracic cavity. Okay. So this is going to be a rapid revision, and we are going to look into important topics. And the main things that we are going to discuss today are going to benefit us both in our university prof exams as well as the NEET or the next PG exams. Okay, let us see more points about it. So here we have some other features. Just let me check. It's moving. Right. So yeah, these are the specific type of questions that can come from here. And if you look, then you can take a screenshot of it and let us discuss some of the important questions. So before going to the topic, let us see what are the important questions that are normally asked in theory, apart from the practicals, right? So in long essay, questions can come like describe the intercostal spaces in detail. Though, let me tell you over here that if it is a long essay type of question, normally nowadays, questions are not framed in this manner. There's some extra points or extra sub points given in each question. Like for example, in this question, discuss the intercostal spaces. They may give this type of question, but normally they give like describe the topic of intercostal spaces under the following headings. For example, they can be like what are the different boundaries of it, what are the different contents of it, or what is the clinical applied of it. All these would comprise, and each subheading will be having different amount of marks. So 2 marks or 3 marks or 3 marks or 2 marks, whatever like this. Then becomes a 10, 15, 20 number of question. Then there'll be a short essay type questions, like write a short note on the muscles of thoracic wall, very important. Or question like describe the diaphragm, including its openings. And here, basically, there is diaphragm over here means the thoracoabdominal diaphragm, the thoracoabdominal diaphragm. Because as you guys will proceed in your anatomical knowledge, you will see that in our body, there are multiple types of diaphragm in different areas of the body. Then question like discuss the structure and function of the endothoracic fascia. A good question. Then what is the role of intercostal nerves in respiration, and mention the boundaries of thoracic cavity and list the layers of thoracic wall from superficial deep. So these sort of questions, and we will touch on all most of these topics in today's discussion also. Then why did you choose Auricle? This I guess you already must have seen a lot of number of times, but still we have recorded live classes, practical sessions, exam modules, and hard copy book set. Here you can look at the recorded classes, live classes. If you want the information in detail, you can take a screenshot of them. Express exam module, one-to-one doubt clearing, hard copy notes, question bank, and your practical sessions as well. And these are different subscription plans that we already have. This previous session also we discussed about them. So we have from 3 months to 4 years, and we have different plans over here, ranging from 19,999 to 189,999. But you can use the code also, and code you can see in the bottom line, Dr. Ankit 20 for various discounts. Let us now move to a topic, and let us make this session a bit more interesting, right? Okay, so here we come to the topic, and the topic, as we all know, is our intercostal spaces, right? So we have a topic. Just a second. Okay, let me use this annotate first of all. So we have a topic of thoracic wall. Thoracic wall. Okay, basically this. So in the previous session, if you remember, then we discussed about the thoracic cage. But what are the things included in thoracic wall? What is cage? Cage is basically we discuss mainly of the bones, the type of bones, the features of bones, the joints between the bones. That is what we discuss. In today's session, what we are going to cover is the wall. Wall is that is bones, and what are the structures that are formed with the help of those bones and the spaces between those bones. That forms a wall. Like in abdomen, we have abdominal wall, we have a thoracic wall. So if you remember, then we had the ribs like this. Okay. So what is between the ribs? What is between the ribs over here? What is between the ribs over here? In between the ribs over here, apart from the skin and fascia, we have muscles. Okay. Then whenever there are muscles, obviously there are going to be nerves and vessels. Okay. And along with vessels, a bit of lymphatics also will be there, no doubt about it. Lymphatics normally runs along with vessels. So we have muscles, we have nerve vessels, and obviously we will have fascias. These are the things which are between the ribs. Okay, they are the ones that are forming the thoracic wall. They are the ones. But for a practical perspective, from practical perspective or practical point of view, what normally we have is that if you talk about the what we can say the entire thoracic wall, suppose someone is doing a dissection, then what actually happens is that you need to cut the skin. No. So in that case, what are the various structures that are encountered once you go or once you take the scalpel? And suppose you have to enter the lungs or the covering of the lungs, that is the pleura. So when you're cutting or when you're doing dissection, when you're operating in an OT, the moment you touch the skin, in your mind, you should know what are the layers which I'm going to cut so that you know, okay, here I need to stop and then here I need to do my procedure, whatever it is, you have to drain or whatever you have to do. So your mind should be very clear that what are the things which I'm going to cut. That is what this education is for. That is what this whole degree of all this numerous number of hours of hard work is for. That in your mind, you already know what you're going to cut. So basically the point over here is the structures or what are the structures in the layers or what are the layers in the thoracic wall so that you know from where to where we are going, how it goes. So let us see about it and just a second. Let me move the page. Just a second. Yeah. Okay. I think, yeah, just give me a minute, guys. Some settings are different over here. Let me see. Just a second. Yeah, now I guess it is good. Look, finally, some setting was there. No problem, guys. So yeah, thoracic wall. So what we're discussing, what are the various structures or what are layers of thoracic wall? Suppose we are going from superficial to deep as we normally approach, right? Superficial to deep. So I will just name the structures with you, and if you can come with me or go along with me in the moment when I'm discussing this, so you can also put your valuable input over here. Okay. Hmm. Just a second, 1 second. Okay. So yeah, layers. Just some confusion now. I guess it is a bit sorted. So to begin with, as we discussed, we have the outer layer that is the skin. The moment you go through the skin, number two is beneath the skin. The skin means basically our epidermis and dermis. Beneath the skin, you have a thin layer of superficial fascia. And if you guys remember, then we did a topic in upper limb that is the mammary gland or the breast. Now, at that time, I told you that this topic or this structure normally it lies in the thoracic wall, but we think, okay, why we're studying it in the upper limb that we discussed over there? That it's a lymphatic and its muscle base is all from the upper limb. So we studied over there. And in the superficial fascia, we have the organ mammary gland. Remember this. So once you cut the skin, and in females, if you are cutting through this region anterior chest, then obviously you will see the breast, a lot of tissue. And once your scalpel is moving behind the superficial fascia, what you next encounter will be what will be the obviously the muscles. And before the muscles, we have a small layer of a thin layer of deep fascia over here. So we have a deep fascia also. And normally in the anterior chest, The major muscle is the pectoralis major. So normally this deep fascia is nothing but a pectoral fascia. Understand this. This will be a pectoral fascia. Then your scalpel has gone beneath the mammary gland. You have cut through the deep fascia, the tough white fibrous. Then once you remove it, you have to be a bit soft in cutting. You have to be a bit precise. Then you see some muscles over here. And you have not yet reached the ribs or the intercostal spaces. Normally, when we have these say 3-4 ribs over here, in between the ribs, we call this as the intercostal spaces. We call it as intercostal spaces. So you haven't reached over here. Still, we are into the muscles. Now, if you remember the anatomy of the mammary gland, what was the muscle that was just beneath the mammary gland? Anterior chest wall. It was mainly our pectoralis major. Yes. So this will come actually. On the sides, you will encounter another muscle that is serratus anterior. Again, these both are the muscles of upper limb. Why? Because their nerve supply was coming from brachial plexus. Understand? Then, if low down, you will encounter another muscle which is external oblique. This is the muscle of the anterior abdominal wall. Low down, anterior chest. These are the few muscles that you encounter. Now, once you go beneath it, number 5 over here. So we had number 1 skin, superficial fascia, deep fascia, muscles. Muscles basically not the intercostal muscles, but the muscles of the upper limb and the abdominal wall. Then once you go, then you will start to look at the ribs. Then comes your ribs. But what is between the ribs? Between the ribs, as I said, number 5, we have the intercostal spaces. Now, in this ICS I'm writing, ICS refers to intercostal spaces. And let me change the color to say black color over here. Here it comes. What is there? There you have some other muscles in the intercostal spaces. So in this spaces, you have some muscles. You have some muscles over here. What are those muscles known as? They are known as intercostal muscles. Simple as that. But it has different layers. From outside to inside, because we are going from superficial to deep. So from outside to inside, you will have, first of all, number A is external intercostal. Then once you cut through the external intercostal, then you have internal intercostal muscles. Then once you cut through the internal intercostal, then you have innermost intercostal muscles. These innermost are again subdivided into, now see, you will have the notes, but I'm trying to teach you from my perspective to understand this basic idea because I am speaking also. Then I'll go through the notes, so don't worry about that. Innermost intercostal over here, we'll have some few subdivisions. Why? Because see, external and internal, they are bit, you can say, a sort of continuous layer. So from back to front, they will be continuous. The external intercostal is more anteriorly, and intercostal is more anterior and posterior also a bit. But this innermost will be in bits and pieces. So this innermost intercostal will have some parts like subcostalis, which is more on the posterior aspect. It will have another part known as sternocostalis, more anterior, obviously telling you sternum, sternocostalis. And then it will also have a transversus thoracis. This will be more on the sides, lateral side. So this is bits and pieces. So they constitute the innermost. So innermost over here has these 3 different subgroups of muscles. But they are where? They are between the ribs. This all story we are referring in intercostal spaces. So between the ribs, we have these different muscles. No, so okay, but why we have so different layer of muscles? That is a good question if that is coming to your mind. But before explaining to that, let me first cover the layers. So once you go through these muscles, once you dissect through these muscles, the 6th layer that you get is a small thin fascia that is beneath the muscle that is known as endothoracic fascia. So understand the word meaning endothoracic. Endo means inside, where thoracic wall. On the inside of thoracic wall, I am a small fascia. I am known as endothoracic fascia. Yes or no? So words are making meanings. They are making a bit sense. Then it's a very thin fascia. Then once you remove the muscles, you see this fascia. Okay, you remove it. Then what do you see? Then you see pleural layers. Pleural layers, we all know there's an outside or outer layer known as, or for outer layer known as parietal pleura. Parietal, parietal pleura. And then you see a pleural space, and then deep to it, you see inner, and this is outer and inner side. On inner side, you will see visceral pleura. So this visceral pleura is actually glued to the lung. So the moment you have touched the visceral pleura, that is, you have touched the lungs over here. So this visceral pleura, I'm highlighting over here, highlighting bit over this visceral pleura or the lungs, they are not a part of thoracic wall because they are the viscera side. So thoracic wall is up to where? The thoracic wall is up to the parietal pleural layer. So it will start with the skin. Number one is skin. I'm now highlighting. Let me take a bit a lighter color. Oh, yes. So start with the skin, the thoracic wall, and it ends with the parietal pleural layer. Not this. I'm not saying in a theoretical way. Okay, that it happens like this. So let us assume there's no assumption over here. This is all scientific knowledge. I will explain you further how. What I have said till now is the thoracic wall will start from the layer of skin and it will end at parietal pleura. Remember this line. I will explain it, or I will give my what we say in quotes. No, that I will give my evidence. Just wait a minute. I'll give the evidence for it. So let us revise all the layers. So after skin, we have superficial fascia, right? Which has the mammary gland in both male and female. Females normally have the whole alveoli and the ducts. The male devoids of the ducts and the alveoli. Mainly few ducts may be there, but alveoli is absent. Then after skin superficial fascia, we have a deep fascia. Anteriorly, normally it is pectoral fascia. Then we have some muscles of upper limb and the abdominal wall, which are the P major, serratus, external oblique, depending on the location. Then we have intercostal spaces, which will have these three different muscles. Then we have a fascia known as endothoracic fascia, and then comes the parietal pleura. That is our thoracic wall. Now, there are two things which I had to explain now. One is why these muscles have different layers, and second is the evidence which I was giving you. So the evidence, let me write directly evidence over here is that why only till parietal pleura we include the thoracic wall. The thoracic wall is from skin to parietal pleura. The reason is that between this skin and parietal pleura, whatever comes, excluding this upper limb muscles, whatever comes is all supplied by intercostal nerves. Intercostal nerves. So it is the intercostal nerves which are going to supply right from skin, superficial fascia, deep fascia, barring this muscle, because these muscles are already supplied by the brachial plexus and abdominal wall. But barring these muscles from skin to parietal pleura, including all these extra intercostal muscles, endothoracic fascia, parietal pleura, they are supplied by intercostal nerves. Now, one thing that can come to your mind is, but sir, what are intercostal nerves for the first timers? Intercostal nerves are nothing but they are thoracic spinal nerves. I am sure you must have heard about the spinal nerves, spinal cord, spinal nerves. So these thoracic spinal nerves, they are known as intercostal nerves. Clear? Then, sir, what about visceral pleura? Isn't it also supplied by intercostal nerves? No. This visceral pleura and the lungs, because visceral pleura is so much attached to the lungs, that whatever nerve fibers will come and supply the lungs, common sense says that they will also supply the visceral pleura, because visceral pleura is sort of glued to the lungs. It is like, that paint on the wall, that paint on the wall. So suppose the wall is made up of brick, cement, or concrete, or whatever it is. Whatever happens to the wall, suppose there is some water leakage in the wall, that water leakage will affect the paint also. So this paint is the visceral pleura, and that brick and cement and concrete, that is the lungs. So these are supplied by the different nerves. What are those nerves? Autonomic nerves, because they are visceral organs. Understand this concept over here. What I'm trying to tell you is the concept over here. Don't forget the main concepts. I repeat again, skin to parietal pleura is the thoracic wall, and thoracic wall is supplied by intercostal nerves. They are the thoracic spinal nerves. Sir, are they pain sensitive? Yes, a big yes. A big yes over here. Let me write over here that they are big pain sensitive. Meaning by what? Meaning by if you take a small pin and you touch on the thoracic wall, obviously pain is perceived. Same amount of pain, or the nerve that is carrying that pain is intercostal nerves or the spinal nerves. They're same thing. They're pain sensitive. So therefore, it tells us that if there's any abnormality or there any pathology, any pus, which is irritating the parietal pleura, again the specific pain. Because here, when we say pain sensitive, it does not mean okay, we'll feel the pain. No, it will feel a localized pain, a specific. Suppose I have a stomach ache. I had a gastroenteritis. I ate something last night outside, and I have that stomach pain. I'll pain in the entire stomach. If I explain my pain, I'll say, okay, pain is in the middle of my abdomen. I don't know. It is diffusely scattered, but it's somewhere in the middle of the abdomen. That is a diffuse pain. But if there is a pin that has been, I picked the pin in my anywhere abdominal wall, I'll tell specific from my tip of my finger. I'll say this is the area where I am feeling the pain. That is Localized, specific, localized. So when we say pain sensitive and intercostal nerves, they are pain sensitive and they are specifically localized over here. So if there's any pathology in any human body, from the skin to the parietal pleura, the pain will be specifically localized. But in this visceral pleura lungs, they are diffuse. The pain is there, but they are diffusely scattered. Or there can be a referred pain to some other area. For example, I give you an example of a gastroenteritis, stomach infection. Okay, so this is our whole thoracic wall. Another point comes that, sir, why are there different muscles? Okay, the second point which I said I will explain to you that why there are different muscles. Okay, so we have this different intercostal muscles. We have different what? We have different intercostal muscles. As I said, we have external, we have internal, and in a nutshell, we have a innermost intercostal muscles. In the previous session, we have discussed that what is the role or what is the function of rib cage. Why we have a rib cage? We have a covering also, and that protects, and also it doesn't hamper in the functioning. So basically, we have a big function of respiration. Therefore, these muscles, how do we identify them? These muscles have different direction of muscle fibers. So external intercostal, if suppose external intercostal direction of muscle fibers is this, just assume the internal intercostal, which is just deep to the external, will have exactly perpendicular direction of muscle fiber. So it helps you in identifying that your scalpel, because after entering to the skin superficial and deep fascia and this reflecting the P major and all, once you see the intercostal muscles, you will see the direction. Okay, this is the direction, and once your scalpel is cutting through it, if the direction changes deep, it is a internal intercostal. And then if once you reflect this layer, this innermost will also be parallel to the internal intercostal. So okay, these three layers I have dissected now. Now I will have a deep fascia over here. That is not a deep fascia, but an endothoracic fascia. And the moment your scalpel or your instrument reaches over here, here you have what? You have the last layer, that is a parietal pleura. Okay. So now this is the end of my thoracic wall. Behind this or deep to this, I have a pleural space. This is having what? There is a thin film of thin layer of fluid, very thin layer. But then that this layer is actually glued, or it is covering it is like a wall. You have reached the wall. This is the paint. Then this paint is visceral pleura, and this brick is the viscera. That is the lungs over here. It is the viscera. So why are these muscle different directions? So respiration. So in inspiration, you need a different movement of the ribs. You need expansion of the whole thoracic cage. So in inspiration, different group of muscles act. Because you need expansion. And suppose in forced expiration, because expiration is normally a recoil phenomenon. But forced expiration, you need different group of muscles. So therefore, the muscle direction is changing. Muscle direction is changing not because they are both not happy with each other. They have a fighting. No, it's not that. It's all function. It is all smoothly functionalized. So in inspiration and expiration, as the volume of the thoracic cavity has to increase and decrease, so the movement of the ribs and the whole entire joints have to change. Because in last session, we talked about what? You said, okay, majority of joints are synovial. You were right. Okay, sir, very good. Now, who is going to move the joint? Joint is there, very good. Synovial fluid is there, very good. But what is the labor over here? Labor means who is going to work. That labor is provided by the muscles. And here are the muscles. These are the labor, which are actually moving at the joint. Why the different directions? Because we have different activities at the thoracic cage. That is the reason. Who will supply these muscles? That if your concepts are good. Intercostal nerves. I've just explained 5-10 minutes back. What are these? Nothing is thoracic spine nerves. Is that clear? So this was a bit of, because I took a bit of time in the beginning, your 15-20 minutes I took in the beginning, just to have you understand this. Now, what are the different things that we are going to cover in this, apart from all this basic knowledge? We are going to look a bit into the nerves, right? That is enough. But again, will come the topic of vessels, which includes both the arteries and the veins. We'll look at them also, what different arteries and veins. Then I'll just let you know, okay, that suppose this is a sternum over here. So imagine sternum over here, and this is a rib, and this is another rib, this is another rib. Okay. If you remember, in the previous session of ribs, we discussed that deep to the lower body of the rib, deep, that is inside of the lower body of the rib, what we had, if you can recall, if you have revised, you will recall, deep to the lower body of the rib, we had a costal groove. We had what? We have a costal groove. And all these neurovascular structures. What is this? Nerve vessels. So what we call it as NVB, neurovascular bundle. It runs in the costal groove. So it is covered by a bone, or it is covered by the lower border of the ribs. So if I try to show you of the artery, suppose the artery is coming like this. This is the artery. Okay, from both the sides, anterior, posterior, arteries will be there. From the posterior side, arteries are coming like this. Same goes with the veins also. Let me some blue color, okay, representing the veins. Let me represent the nerves also. That is this color. So here you have the nerves also. So all these neurovascular structures, they are near which border? If I ask you a very simple common sense question, are they near the upper border or the lower border? You'll say, "Oh, what is it? Simple question. Lower border, sir." You're just saying coastal, yes. So it is all these structures, this neurovascular bundle is near the lower border. Now, if you have to do some instrumentation, if you have to reach the pleural space, I'm showing the diagram, looks very big, but understand the patient is lying down in pain and suffering. Now there's some bleeding going on happening. Patient is in dyspnea, not able to breathe. So you can understand situation. That is why theory is one thing, practical is another thing. So I mean, this enhance your knowledge, but also it is incomplete if you don't go to the wards, don't go to the medicine wards, respiratory wards, and see over there. That is where the correct application has to come. The things are going to be very different. Always advise in MBBS, don't forget your clinical rounds. They are very, very important. And if you have time, nothing to do, much better than your social media handles or your Netflix and all that. Visit any ward. Okay. See some activities over there, talk to your seniors, ask, seek their help. Fair enough. So if you're doing an instrumentation, will you take your instrument closer to the lower border or the upper border? So obviously we'll take to the upper border because lower border we have these things. So yes, that is the whole point. That is what the question comes. That if you're doing any instrumentation, never bring your instrument close to the lower border of the rib. Always go at the middle or near the upper border. But if there is an emergency, patient's already dying and you're not, and obviously these things don't come into play, you have to enter inside. Then you can enter inside. If there's a small damage to the vessel, let it be. But theoretically, when a question comes, you have to understand. So in this session, we are going to discuss the nerves, a bit of vessels, and the vessels, the neurovascular bundle structures. I'll see muscles also, and these are the things that you're going to see. Now let us come to the notes and see what we can gather from notes. We'll come back again to this, and we'll take our what we said, our study from here. Just a second. Okay. Okay. I can't see the notes right now. No worries. Okay, let me continue from here only. We'll continue from here, no problem. Let us continue from here. Just a second. Right over here. Yes. So nerves, I guess we have come to know that there are intercostal nerves, and how many intercostal nerves are there? We start with the nerves. So there are 12 what pair? 12 pair of intercostal nerves. Okay. 12 pair of intercostal nerves. Be with me. Next 15-20 minutes, you'll understand many things. So this we know, there are 12 pair of intercostal nerves. What are these? Nothing but thoracic spinal nerves. Thoracic spinal nerves. We have 12 vertebrae, thoracic vertebrae, we have 12 pair of intercostal or 12 pair of thoracic nerves. Out of this 12 pair, we have T1 till we go till T12. The question has come in the previous time. But okay, tell us what are the typical intercostal nerves? Question has come. Remember, the typical intercostal nerves are now number T3 to T6 only. 3, 4, 5, 6, the middle four. These are the typical intercostal nerves. So, then question comes of why these are typical. What is the difference in typical, atypical? That should come to your mind. The typical intercostal nerve is the nerve which is only supplying, only is a big word, only supplying the thoracic wall. You'll under, sir, it means that other ones are supplying something else also. Also, yes, they are supplying something else also. So please tell us what. So then I can put some questions to you. Okay, T1, T2, I hope you guys can answer if you have gone through the upper line. T1, see, other thoracic spinal nerves, T1, T2, or T7, T8, T9, T10, T11, T12. From T1 to T12, all are supplying the thoracic wall. But only T3 to T6 is only supplying the thoracic wall. Others are supplying something else also. So T1, T2 are supplying what? T1, if you remember, is a part of brachial plexus. So it is also going to UL upper limb. T2, that's question for you guys. Pause and try to answer. That or its lateral cutaneous branch, the lateral cutaneous branch of this T2, that is second thoracic spinal nerve, the lateral cutaneous branch of this particular nerve, that goes and supply again upper limb, the floor of axilla. That is known as intercostobrachial nerve. So T1, T2, although they supply the intercostal spaces, or they also supply the thoracic wall, but in addition to it, they will also supply the other areas also. Okay, sir, fair enough. But sir, what about T7 to T12? That's a huge number. T7, T8, T9, T10, T11. What do they supply apart from thoracic wall? That common sense thing. You guys try to answer. If I give you a hint over here that the lower limb is basically supplied by lumbar and sacral spinal nerves. The lower limb. Okay. So think what this lower half of thoracic spinal nerves is in addition going to supply. They are going to supply the abdominal wall. Some of you might be thinking that's an abdomen. Behind abdomen, we have the lumbar vertebrae. I will say absolutely correct. Behind the abdomen or in the post-abdominal wall, we have the lumbar vertebrae. No doubt about it. But the nerves that are coming out from the lumbar vertebrae, they are not supplying the abdominal wall. They will form the lumbosacral plexus. And then they are going to go down. They are going to supply the inguinal region and the lower limb region. What about the abdominal wall? By these nerves. The typical intercostal nerve is T3 to T6. I hope you can remember it. Typical intercostal nerve is T3 to T6. That is the point of nerve. What are they going to supply? So thoracic wall. What in thoracic wall? Sir, from the skin to parietal pleura. Don't forget that. Including intercostal muscles also. Okay, that's the point. That is about the nerves. Any doubt? I hope not. Okay. Next, let's come in thoracic wall. Let's come to the part of vessels. And vessels, let us see the arteries. Why is it important? We are doing, I mean, you should know the arterial supply. It's important in many, many ways. I know the most important application of these arteries is, first of all, in any stab injury or gunshot injury, any penetrating wound, there's a bleeding, you should know this artery is a branch of which artery. Normally, see, Medicos, medical student, medical life, we are normally known. And right now in the current generation, not current generation, but in past many years, few years, say 30, 40 years, when the technology all has started to increase, we have become a bit impatient. So whenever topic comes like this is artery, is a branch of this artery, and the point comes, okay, sir, why are we reading this? It is so rectification, it is so cramming everything, because majority of our school time has been passed in cramming a lot of subjects. Okay, so it comes to a mindset, okay, we have to cram again and again, and that decreases the interest. But here comes the point, you should understand why you're studying any topic. So suppose I'm going to tell you, okay, this artery is going to be a branch of any artery. Okay, we have to see some branches. And the first question that should come to your mind is why. The reason why is tomorrow, if you are seeing any case, any stab wound, and bleeding is occurring over there, you're not able to stop the bleeding. And if you know, okay, that this is a vessel, okay, and here I am seeing some blood that is dripping down, okay, and the whole clothes and the bed sheet and all, they're having red color. Okay, now forget about everything. As BP is coming down to 80/60, pulse is going high in 120. Okay, and obviously in pain and all that, the relatives who are seeing the blood, they are again fainting down. The patient might be conscious or not, that is the other thing. But now your role is not about controlling the relatives and seeing their flow. That is the other thing. But your role over is save this. So your bleeding is coming out from any artery. What you can do is, you also know I will compress it. How long will you compress it? Okay, but even after all doing all this compression, all the bleeding again starts. Then if you know that, okay, this artery is a branch of some other artery, and you know this is a branch of which artery, and if you can compress this artery over here, the parent artery, whatever small bleeders over here, they will automatically stop. Therefore, we should have a rough idea of where this bleeding is coming, or it is a branch of which parent artery, that we should know. Suppose you're doing any instrumentation between the ribs, again bleeding starts. Have a good idea from where the artery is coming from. Okay, so now let's see the arteries and their branches. Main point over here. So arteries and their branches. Now, so we have to again go back to the thoracic cage structure, just to ask you a few things. Suppose this is the anterior side. We are looking at a sternum. Okay, here is a rib 1, a rib 2, 3, 4, 5, 6, and 7, and then we have 8, 9, and 10. Similarly, we have 7, 8, 9, and 10. Okay. Now, this is rib number 9, this is rib number 10, that is rib number 1, rib number 2. Understand what was above rib number 1? Above rib number 1 was your, say, the region of the neck, and here we have the bone is clavicle. So, this region between 1 and 2, this is known as first intercostal space. Is that clear? Anteriorly or in the anterior thoracic cage, how many ribs we have? So about 11th and 12th. Yes, sir, I remember 11th and 12th, they were floating ribs. So will they come anteriorly? No, I don't think so. Right? So anteriorly we have how many ribs? 10 ribs. So anteriorly, how many spaces will be there? How many spaces? Yes, sir. So between 9 and 10. If between 1 and 2 is the first space, then between 9 and 2 will be the 9th intercostal space. And I hope by now you know the counting of the ribs, which I have explained in the previous session. No need to reproduce it again. So we have 9 intercostal spaces. So therefore, anteriorly, when we are talking of an artery, all each space will have 2 anterior intercostal. But anteriorly, we have around 9. We have around 9 anterior intercostal arteries. We have 9 anterior intercostal arteries. Why? Because there are 9 spaces only. So now, if I try to draw an artery over here, just lateral to the sternum, there's an artery. There's an artery over here, which is deep to the ribs, not over the ribs, it is deep to the ribs. Okay. So it is deep to the ribs, and let me just okay, let it be. So this artery over here, what is the name of this artery? Point number 1. And let me tell you its clinical use also. It is just around I must say half inch or around 1 centimeter lateral to the lateral border of sternum. So let me make it on the right side also. This is an artery over here coming down. Is that clear now? Okay. And over it, let me draw a couple of ribs over here. So we are making some ribs over here. So now you know exactly, okay, there it goes. Now if I ask you, okay, which artery is this? And it's and very, very important clinical uses. It is used in your cardiac bypass operations. In the cardiac arteries or the coronary arteries, they are blocked. To bypass them, you need a natural artery. This is the one of the most preferred arteries that is taken. And the name also cardiac or coronary artery bypass grafting, CABG, normally we call it as. Very important clinical use. I hope you all know about the how number of bypass operations daily worldwide we have. Forget about the India. So what is the name of this artery? The name of this artery is internal thoracic artery. So all these, you can say the 9 spaces arteries are basically branches of internal thoracic. So it will, so upper 9, or you can say the 9 spaces over here, they are coming from internal thoracic. But internal thoracic, if you look over here at the lower part of the sternum, here it divides into 2 branches, 1 and 2. This is 1, this is 2. So this lower 3 spaces, no, their branches coming from this number 2, but it is again a branch of internal thoracic only. So what are the name of these branches? Number 1 over here is known as superior epigastric artery. Which artery? Superior epigastric artery. So where it is going? Abdominal wall, upper abdominal wall. It is, this superior epigastric has nothing to do with the thoracic wall. Its name is superior epigastric. Where is the epigastric region? Is where we have the stomach. You'll read in the abdominal wall. We have 9 regions of abdominal wall. Epigastric is the one which is for the stomach. This is superior epigastric artery. The other artery over here, you're seeing over here, this is the musculophrenic artery. Which artery? Musculophrenic artery. So both of the superior epigastric musculophrenic, they are branches of internal thoracic. This musculophrenic will give out of the 9 intercostal, this will give the lower 3, that is your 7th, 8th, and 9th anterior intercostal artery. Suppose tomorrow question comes, the 8th anterior intercostal artery is a branch of. Both any on right or left side. One of the options musculophrenic, go with musculophrenic. If musculophrenic is not in the option, then second best answer will be the internal thoracic, because musculophrenic itself is a branch of internal thoracic. Upper six over here, the upper six over here, they are coming directly from, or you can write upper six, that is 1 to 6. What? Anterior ICA, intercostal artery. They are branches of what? They are upper six, 1 to 6. And intercostal, let me change the color, it's becoming a bit monotonous. They are coming directly from internal thoracic artery. Internal thoracic artery. I hope the point is somewhat clear. Now, my another question. Fine, you know it is in the thoracic artery. Good. But there has to be some artery over here which is giving off internal thoracic. Which artery is this? Go back till you reach the heart. This artery over here is subclavian artery. Which artery? Subclavian artery. Okay. Subclavian artery is a branch. Subclavian artery normally comes around the arch of aorta. So you have now somewhat reached near the heart only, because already said it. So at least remember, subclavian artery gives off the internal thoracic, which is lying lateral to the sternum, and it will give the upper six anti-intercostal. So let me use a highlighter over here. Just trying to revise things. The subclavian artery will give off what? Gives off the internal thoracic artery, which will supply mainly the upper six anti-intercostal arteries. But this internal thoracic will give off musculophrenic over here, which supplies the lower three, that is 7th and 8th and 9th. Anterior, we have 10 ribs, so 9 spaces. Like we have, how many fingers I'm trying to show you? How many fingers are there? 5 fingers. How many interdigital spaces we have? 1, 2, 3, 4. Between the finger, we call it as the interdigital space. First space, second, third, and fourth. 5 finger, 4 spaces. 10 ribs, 9 spaces. Anterior, this is the point. Now comes to the posterior aspect. So let us look at the arteries, but in a posterior aspect. Okay, let us do that also. So let us look at this arteries, but which artery is posterior intercostal artery. Okay. Now, and the first question that should come to your mind is, okay, sir, is sir going to ask us that how many spaces are there? Yes, I'm going to ask you. So if you look at the posterior image, we have 12 thoracic vertebrae. So let me just try to draw a line over here, a couple of two parallel lines. I'm trying my best to draw them, but fine. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, and 12th one already. This one, right? 3, 4, 5, 6, 7, 8, 9, 10, 11. These are, imagine the 12 thoracic vertebrae. Okay. And each one is having its own ribs. So posteriorly, you have rib number 12, rib number 1. So this between 11 and 12 ribs, which space will be over here? The 11th intercostal space. Okay, so we have the ribs that are going. I'm not going to draw each rib, but just understand. For understanding, we are making these are the vertebrae, the thoracic vertebrae. Clear? We know that the ribs are coming out. Now, so posteriorly we have 11 intercostal spaces. So we will have 11 posterior intercostal arteries. Bracket I am writing, we had 9 anterior intercostal arteries. Okay, in your back of the mind, should recall these things also. Now, first of all, bit of straightforward factual situation. Out of the 11 posterior intercostal arteries, it divides into upper 2 and lower 9 posterior intercostal arteries. Simple as that. The upper 2 posterior intercostal arteries, they are basically directly, indirectly, they are branches from subclavian. So we have subclavian artery. Remember the same subclavian artery that gave off the internal thoracic. So this subclavian artery is going to give us the costocervical what? Trunk. This costocervical trunk, look at the sequence of branches. It gives off the superior intercostal artery. Okay, and this artery will give off the upper 2. I'm writing pica, posterior intercostal artery, upper 2. This U2 is upper 2. Point clear? So they are basically branches of subclavian artery. So what about the lower 9? Lower 9, they are directly coming from the thoracic part of the aorta. Aorta, sir? Yes, sir. Aorta. Okay, sir. Aorta, fine. Fine, sir. Okay, good. But my job over is not to give you facts, because facts are everywhere. My job over is how I can make it a bit easier for you to understand. So for that, we have to look at the lateral view. Which view? Lateral view. Okay, so let me try to make one more structure over here in this next slide. Let us make a lateral view. So laterally, suppose this is the anterior aspect, that is say the posterior aspect. Okay, so we have this manubrium, then we have the body of the sternum, and we have this zip process. Okay, and here we have what? Here we have this. Imagine the try to imagine it as a thoracic vertebrae having an anterior concavity. Okay, so writing V for vertebrae, and this is S for sternum. Okay, so why I am trying to make this? I'll tell you why I'm trying to make this. Okay, fair enough. Okay, so if this is the T1 vertebrae, so hypothetically, which rib will it be going from T1 to the manubrium? So first rib, very good. This is the first rib. See, I am answering on behalf of you guys only. I am sure that you can answer much faster than what I'm answering. But this will be the first rib. Okay. Now, why I'm making this? Because over here I have to show the aorta also. So the heart is normally situated like this. Imagine this is the H for heart over here. And this will be the ascending aorta. And here, just behind the manubrium, you have the arch of this. Arch will go like this, and then it will come behind, and then it goes down like this. This is your arch of aorta and the thoracic aorta. So this is the arch of aorta. Let's make it a bit longer. Arch of aorta, and this over here is thoracic aorta. Okay, sir. Fine, sir. Fine, sir. But sir, why are you explaining? Just give me one more minute. I'll tell you why I'm explaining this. From the sternal angle, if there's a rib that is going, which rib will it be? Sir, second rib, sir. Yes, very good. So right over here, what? Second RIB rib. Okay. Now from the arch of aorta, what branches come out? What, sir? Arch of aorta? Sir, I remember, sir. Okay. Tell us which branch comes from the arch of aorta. Okay, sir. So this is the arch of aorta. So, sir, first branch here will be the brachiocephalic trunk. Very good, beta. This brachiocephalic trunk divides into right subclavian. Very good. And a right common carotid. Very good. Fantastic. Right common carotid. Then, sir, another branch comes is the left common carotid. Very good. Left common carotid artery. And then, sir, we have one more over here. That is the left subclavian. Very good. We have left subclavian. Okay, this is normally that comes out from the arch of aorta. Okay. I want you guys to focus on the two subclavian arteries over here, the right subclavian and the left subclavian. Subclavian means where are they going? They are going towards the axilla. If you remember the subclavian arteries from the upper limb, both subclavian arteries, they will arch over the first rib, and then they will continue into the axilla as the axillary artery. Yes or no? If you remember the axilla topic, when we discuss the axillary artery, you will recall this. Okay. So let me over here try to show you again that imagine this is we are seeing on the left side. Just try to imagine here comes the left subclavian artery, which is then going outward. No, so it runs like this into the axilla, and then it will come out to the left upper limb. Fair enough. I hope you have got the point. That if you look at this line over here, this line is actually going through the sternal angle. So this whole aorta is arch of aorta above, and below this is thoracic aorta. If you look at the first and second space over here, what do you think? Will it be supplied by this subclavian artery, or will it be supplied by the thoracic aorta? Answer will come automatically. Yes, the subclavian artery is at that level only. Yes. Therefore, if you look at the previous image, the upper two regions, therefore, they were supplied to subclavian artery. They give off cervical trunk, which gave off the superior intercostal, which is supplied this. Now, if you look at the lower 9 spaces, because here it will go directly from here. Third, fourth, fifth, sixth, seven, 8, 9, 10, 11. In the lower 9 spaces, the lower 9 posterior intercostal arteries, they come directly from the thoracic aorta. Now, my next question to you is, suppose this is we are looking at the back side, this is the, let's say the right side, that is say the left side. Aorta is normally on which side, right or left side of the midline? So it is on the left side midline, very good. So normally the aorta runs like this. Imagine we are looking at a posterior view. The previous one was a lateral view. This was a left lateral. Okay. I hope you got the point. Focus on anterior posterior, left lateral view. And so let me write over here also, because I know in the first year we have a lot of problem with the this anterior, posterior, medial, lateral, superficial, deep, superior, inferior, all that, right? Because yeah, I can understand the beginning it comes. But here, imagine it's the posterior view. Now this is the thoracic aorta. This is our thoracic aorta. Okay, and here now's the time when I can make few ribs over here. So let me try to make 1, 2, 3, 4 ribs over here, and 4 ribs on the right side also. Okay, now look at the posterior intercostal artery. This is the left-sided posterior intercostal artery. Which sided? Left-sided. This is posterior intercostal artery on the left side. And if I try to make over here, this is the right posterior intercostal artery. Which artery? Right side, PIC. Okay, looking at the image, tell me which sided posterior intercostal artery. Two questions. Will cross the midline and which is longer in its course. That is, these are two questions, different questions which have already come in the exam. Question number one is that which of them crosses midline. Well, then you might think that's a what sort of silly question. Does they're asking some KBC? Is there some KBC sort of a quiz show what it is? But when surgeon is doing an operation, no, and when they're operating near the midline, and when they are seeing the vessels, their mind should be clear. At that time of surgeon, when the scalpel, this whole mask and lights are there, and so much of stress is there, anesthesia is running on, a lot of machines are already operating, the disease, they they don't have much time to think. There some reflexes will. So the knowledge will come directly. Suppose you are removing the lymph nodes, you are removing the lymphatics in the midline. You should know that okay, the vessel is I'm seeing a vessel. Which vessel is this? I should be clear. Because tomorrow that vessel somehow bleeds. You should know again, no, that's coming from where, so which artery I can compress to just slow down the bleeding and blah blah different things. So which out of right and left side crossing midline, obviously, as we have seen already, it is the right-sided posterior intercostal artery, which is longer again, crossing the midline, crosses midline, and longer in the course. Longer is the right side. Both question answer is same. That is the right-sided posterior intercostal artery. Upper two by subclavian artery, branch to branch, and lower 9 spaces directly by the thoracic aorta, left and right. Right one crossing the midline, and obviously, therefore, longer in the course. Point clear? Okay, this was about the anterior over here and the posterior intercostal arteries, upper to a lower 9 spaces like that. Now comes, okay, sir. So can we discuss some of the veins also? Let us see. So posterior and anterior, or we can just write intercostal veins. There are few points over here which we need to focus. Okay, you need to bit of focus over here. What are that? One is intercostal veins we are studying. So okay, so anterior and posterior side, because similarly we have the arteries. Now, if you go back, what was the which artery gave of the entry intercostal artery? So entry intercostal artery, so it was internal thoracic artery mainly gave. Okay. Now if I ask you a basic question, like for example, there is axillary artery, then there's axillary vein, right, sir? Subclavian artery, subclavian vein. Okay, sir. Femoral artery, femoral vein. Okay. Brachial artery, there's also a small brachial veins or group of brachial veins. So normally when you have an artery, we have a opposite direction flowing, we have a blood, that is a venous blood. And names are more or less similar. Same happens over here also. We have anti-intercostal artery, we have anti-intercostal veins. As they were coming from the internal thoracic artery, anterior side, so the veins will go where? Anterior side, the veins will go to internal thoracic veins. Fine, sir. Sir, but what were you trying to explain past 15-20 seconds? Giving what I was trying to explain is here is a very, very good question, which in my memory I have, I guess, seen once only when the DNB exam was separate exams. What was that question? The question was, listen to the question. I will try to ask you also. If you can tell me the internal thoracic artery was a branch of which artery? I hope I told you. You can answer. And I'm sure most of you have already answered this subclavian arteries. Very good. Now, same question if I ask you that, okay, internal thoracic vein will drain into which vein? Then the reflex response is a subclavian vein. There is a subclavian vein, yes, but that is not the answer. Here the answer changes to brachiocephalic. So remember this. This is a very, very good question. Brachiocephalic vein. The internal thoracic veins, where all the anterior intercostal veins will drain. So all the anterior, not the posterior, all the anterior intercostal veins will drain where? Into the internal thoracic vein. But this won't go into subclavian vein, it will go to the brachiocephalic vein. Clear? Simple question, but worth to note. Worth to note. Now here comes the posterior. A posterior, what we have? Posterior intercostal veins, very good. So posterior, which was the main artery that was supplying, sir, it was thoracic aorta. Okay. So which vein will be there? Which vein? There is a thoracic vein. There is no comparable vein like the same size of the aorta near the aorta, near the thoracic aorta per se. Sir, how, sir? Let me try to explain you in a bigger picture. Okay, things become a bit interesting. So suppose this is the head. Okay, this head and neck for understanding, right? So pardon my beautiful drawing. And here we have the upper limb. Okay, and here we have this trunk part, and we have this lower limb. Fine, understand, try to understand. First of all, let me try to make the aorta. So this will be your ascending aorta, the arch of aorta, and then it goes down, becomes the thoracic aorta, and then it becomes the abdominal aorta, and then it divides into what the common iliac arteries and all that. So this is normally what happens, and obviously it gives a lot of branching. So, sir, what are you trying to tell us? Just give me 1 second. In the upper part of aorta, there is a comparable vein that is coming down. Which vein is this? Most of you, I hope, can answer. Superior vena cava. In the lower part of, or you can say in the abdominal part of aorta, we have another vein that is parallel to it. Which vein is it? It is inferior vena cava. Very good. But where are they both entering into? So they are both entering into the heart. Let me make our school time heart. So what is school time heart? School time heart is this heart. Yes or no? Okay, better to understand. So these both superior vena cava, inferior vena cava are entering over here. They are comparable to the upper part of aorta, lower part of it. But what about this aorta? That is a thoracic aorta. There is no vein which is comparable like SVC, IVC over here. But there is a vein which connects the SVC to IVC. There is a vein which is connecting, and try to understand, SVC to IVC. Okay, sir. Which vein is that? For those of you who have not heard about its name, now you can say we have heard that is azygous system of veins. Okay, sir, azygous system. Fine, sir. So yes, most of the posterior intercostal veins, they drain into azygous system of vein. A few points of azygous system of vein, and I can tell you what that. Suppose this is the vertebral column. This azygous, that is thoracic vertebral column, the azygous vein will be on the right side. Okay, it is connecting the SVC to the IVC. That is very, very important thing to remember. I'm not going to the small factual information, but understand this. First of all, azygous vein is towards the right side of midline. It is unpaired. It is single on. Then, sir, you are saying, sir, that the left posterior intercostal veins will cross the midline. No. Why? Let me tell you that information. Also, here you have small hemiazygous veins. And these hemiazygous and accessory hemiazygous. So what are these? These are hemiazygous and accessory hemiazygous veins. These drain the left posterior intercostal and then they go to azygous. So basically, directly or indirectly, all the posterior intercostal veins are draining into azygous vein, directly or indirectly. And then this azygous vein drains into SVC. It is connecting IVC to SVC. It does not mean that, okay, lower one will go to IVC. No. The blood has to ultimately reach the heart only. So this azygous vein, normally, under normal conditions, they all drain into SVC, which goes into the right atrium of heart, RA of heart. Yes or no? Okay, sir, fine. So we have azygous vein, yes. Which is on the right side of midline, yes. So points, let me write over here. It is on the right side of midline, RIGHT, RIGHNT, okay. And it connects SVC to IVC, okay. And other veins in the, because if we are saying it, what we are saying is system of veins. Other are your hemiazygous and accessory hemiazygous vein. but ultimately they also drain into azygos, which drains into SVC. Fine, sir. Got it? Okay, got it. Very good. Now, you might wonder if you are observant enough that I have said 2, 3 times or maybe 4 times it connects SVC to IVC. What is the relevance of this? Here comes the importance. Now the respect for this azygos vein will increase manifold suddenly. Till now it was just a simple vein draining the posterior intercostal vein, but now the respect over here comes. The SVC, IVC, they are both veins. So their wall will be thick or thin. Their wall will be paper thin, paper-like wall. Okay. I'm sure some of you might have dissected the veins and must have seen them. If not, then near future you will do it. Therefore, the point over here is when the wall is very thin, then this wall can be easily compressed by any growth or any collection of any fluid or whatever it is. Therefore, there will be instances in your clinical life or emergency life, then we will see SVC or IVC obstruction cases. Okay. In that case, what actually happens? Suppose the IVC is blocked. In simple, let me tell you, pregnancy. In the later months of pregnancy, in third trimester, when the uterus has enlarged too much into it reaches the umbilicus and above umbilicus also, it might compress IVC. So whenever it's a physiological thing, but in diseases also, IVC might be compressed. So when there's a compression, then this azygos comes in as a savior. It diverts the blood from IVC to SVC and then into, because the circulation should happen. Because if you have blocked the SVC or IVC, I can imagine how much of engorgement of blood will be there. Yes or no? At that time, the azygos vein comes into play. And it actually protects the entire body. It is like a bypass. It is like a bypass. Okay, it's like a bypass. Suppose, imagine you have a big we can say a big airport over here. Okay, and this airport is connected to two major cities. Okay, two major cities, and these are the two major cities. Suppose this is NH1 and this is say NH2. National Highway 1, National Highway 2. This is a big airport which is connecting these two points. Suppose there's any accident over here, any blockage over here, any dharnas over here, so this road is blocked. So what will happen to this entire big city? All the clients and customers over here, all the passengers, so what will happen to them? At that time, there's a small road which goes from NH1 to NH2. That is the azygos vein over here. Okay, this is azygos vein over, and this airport is actually nothing but the heart. It comes like that. Okay, so remember it like that. This was the whole venous drainage. So we have seen today what the arteries, the veins, the nerves. Nerves, remember what are the typical intercostal nerves that I guess we discussed over here. And what were the layers in the thoracic wall? What is pain sensitivity? What is not pain sensitive? Okay, these are things which we have discussed over here. And I hope you enjoyed. If there's any other discussion, any other queries, let us know. We'll be more than happy to help. So that's all on my side. Bye-bye. Take care. Good night. And thank you.